Dr. Murali, yeah, unmute, Dr. Murali. Click on the unmute option. It's still muted. There's an unmute option at the bottom.
Yeah.
Yes, excellent. Thank you very much for your time in joining, sir. So, dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our moderators, Dr. Murli and Dr. Himamala, to start this session. Thank you, and over to you.
Thank you, sir. Dr. Hema, you can proceed.
Okay. Thank you. So we welcome you all to this session. So first we'll have a clinical case discussion, which was an interesting presentations when we started investigating. And then the second part will be from Dr. Palaniappan. So I request our first year PG, Sneha, to go ahead with the presentation.
Okay, good evening all. I'll be discussing an interesting case scenario. We had a 15-year-old female who presented to us with complaints of yellowish discoloration of eyes since 4 months, and both leg swelling since 2 months, and abdominal pain which was present on and off for about 10 days. So her yellowish discoloration complaint was present for 4 months. It started insidiously and it was progressive in nature, and it was not preceded by fever, body pain, or chills, and not associated with itching or pale colored stools. There was no associated vomiting or loose stools. She had complaints of bilateral leg swelling, which was for 2 months. That also was insidious in onset, non progressive, and she did not have any associated skin changes. And along with this, there was no associated abdominal distension or decreased urine output or any breathlessness, chest pain. Then patient also had complaints of abdominal pain on and off for 10 days. It is dull aching, intermittent. It was diffusely present and not related to food intake. And she said that it started after medication intake, which was prescribed in a hospital at her native place. She also complained of mild stiffness of bilateral lower limbs while walking, and which also later developed in her hands. So she had difficulty in writing, and this was mild and intermittent on and off. So since 4 months, and it was non-progressive in nature. And there was no associated involuntary movements, and her scholastic performance in school was very good. So there was no hindrance in academic activity. Then there was no associated history of bleeding manifestation, loss of weight or loss of appetite, or no history of any altered sensorium. Now there is a significant treatment history. Patient had history of native medication intake for around 6 days. After she developed jaundice, she took around 6 doses for 6 days. But since the symptoms persisted, she went to a higher center for treatment in Hyderabad. So this happened in April 2022. The past history of the girl, there was no history of jaundice in the past, and her birth history also was normal with no history of jaundice at birth. Then no previous complaints of abdominal distension or leg swelling, and no history of blood transfusion, tattooing, or comorbidities. She has gained menarche, and right now she's having oligomenorrhea. Periods is once in 2 months. There is a significant family history. Patient's parents had a consanguineous marriage of second degree, and she did not have any siblings, and she was the only child. And other family members didn't complain of any similar complaints. So now to summarize the history so far, A 15-year-old female presented with jaundice since 4 months, bilateral lower limb swelling since 2 months, associated with mild neurological symptoms, which was non-progressive, not associated with cholestatic features or bleeding manifestations, and with no features suggestive of ascites or hepatic encephalopathy. At this stage, we will have a few DDs in our mind because she's having jaundice associated with neurological symptoms and she has a genetic consanguinity history of her parents. So we will think in terms of any genetic conditions which can be metabolic or autoimmune. So these are the differentials in mind, and patient had native medication intake also, which is very important. Now I'll proceed with the general examination. Patient is conscious, oriented to time and place, and she was moderately built and nourished. BMI was 20, and icterus was present with bilateral pitting pedal edema and no other significant history. Examination findings. Then vitals was also normal. The pulse rate, BP measured, everything was did not have any abnormal findings. And she was afebrile, and respiratory rate also was regular, 14 per minute. Proceeding to the abdomen examination. On inspection, her abdomen was scaphoid in shape, flat. The flanks were free, and there was no visible striae or scars or dilated veins seen. And on palpation, liver was around 2 to 3 centimeters palpable below the right costal margin in the mid-clavicular line, moving with respiration, smooth surface and rounded edge. Spleen was not palpable. Percussion finding, there was no fluid thrill or shifting dullness, and vertical liver span along the right mid-clavicular line was 12 centimeters. And on auscultation, bowel sounds were present. Other system examination, CNS, she did not have any flaps or asterixes, and there was no rigidity present in upper or lower limb. CVS and RS system examination was normal. Now, at the end of history and examination, we arrive at this impression, a case of acute hepatitis with no ascites, hepatic encephalopathy, or coagulopathy. And the probable etiology we have in mind is metabolic and with an overlay of any drug induced or autoimmune or viral. Viral is unlikely because she did not have any prodromal symptoms. But since patient can have hepatitis without viral etiology without prodromal symptoms, we are considering it as our last etiology. Now, when the patient presented to us, she already had a investigation and treatment history of around 3 weeks in another hospital in Hyderabad. So the presentation in that hospital, the first presentation to hospital, I'll be presenting where this is the hemoglobin 10.7 with total count 5,200, platelets 1.52 lakh, and the LFT shows a total bilirubin, which is in hyperbilirubinemia, which is direct more than indirect. She's have had till 6.5 on 25th April, and then it has come down to 4.7. She also took the medication, native medication around this time, 25th April. She has taken a native medication also after the jaundice has begun. And we can also see the INR is elevated 2.6, AST, ALT, there's transaminitis. And so this is the picture which she presented us to us with. And there were other investigations which were done in the outside hospital. First, all the viral markers were negative for hepatitis B, C, then A, E, and HIV. Everything was negative. But there was an interesting finding of autoimmune marker ANA, which was positive in a significant titer, which is 1:160. And but the other autoimmune markers like anti-LKM, ASMA, AMA were negative. And serum immunoglobulin IgG total also was elevated, which was 2,316. And then when we did the copper profile and iron profile, we found that serum ceruloplasmin was low, which was significant, 6.5 milligram per deciliter. And 24-hour urinary copper was significantly elevated, 1723.52. And serum ferritin was it was okay, 398. And she also had an ophthal evaluation, and on slit lamp she was found to have a case of Lischer ring. Otherwise, lipid profile and TSH is normal. So from this, we can see that serologically, even there is evidence of low copper and high urine copper excretion, and autoimmune etiology can be seen. And because KF ring is there, we are thinking in terms of um, Wilson with an autoimmune etiology. So the other imaging investigations, ultrasound showed a diffuse altered ecotexture of liver with periportal echogenicity and borderline splenomegaly. They also had done a UGI scopy which showed prominent esophageal veins. Liver biopsy, it showed a hepatitis pattern of injury with fibrosis and regenerative nodules. And there was this rhodinin stain is used to stain copper, and it showed that a random patchy copper accumulation, intracytoplasmic copper accumulation was there. And along with that, plasma cells with rosetting pattern was noted, which is very typical of autoimmune hepatitis. This is the scoring system of Wilson and autoimmune hepatitis. On the left side, you can see the Wilson's disease scoring. Now, for this patient, she had a KF ring. She had mild neurological symptoms. There was low serum ceruloplasmin. There was no hemolytic anemia, rhodinin positive granules, and urinary copper is elevated. Mutational analysis was not done. So the score is coming 4, 5. Score is coming 7. So it's an established case of Wilson. And on the right side, you can see the scoring of autoimmune hepatitis. This actually, we had repeated few markers later on. I'll be showing in the proceeding slides. So according to that, we found that it's fitting in the criteria of other autoantibodies also positive, anti-LKM1, anti-SLA. Then IgG is elevated. Histological findings are typical. So this is also showing a definite score for autoimmune hepatitis. So now, right now, our diagnosis Wilson chronic liver disease secondary to Wilson's and autoimmune hepatitis. And she was started on penicillamine 250 mg along with prednisolone. Initially, it was 30 mg and then tapering dose, and azathioprine 50 mg. So we, when the patient presented to us, we asked for review of the histology, the liver biopsy slides. So this picture shows the periportal area and on the right side liver parenchyma. So we can see the lymphocytic infiltrate proceeding, encroaching the parenchyma. So this is classical of interface hepatitis. And this is the zoomed picture of the same slide where I have highlighted the plasma cells. This is typical of autoimmune hepatitis. Along with lymphocytes, plasma cells are also seen. And reticulin stain showed this rosette. You can see these lobules, lobular pattern. These so they are called rosette. So these are the rosettes which are classically seen in autoimmune hepatitis. So this histologically, it is showing in favor of autoimmune hepatitis. We are not able to find much of this copper granules. There were very few random copper stain patches. And so this is the final review of the slide. Features such as suggestive of chronic active hepatitis, suggestive of autoimmune etiology with this grade 3 activity and stage 3 fibrosis. And we have repeated in our hospital all the investigations to confirm so that we can proceed with the treatment. Serum copper was low, 32.76, ceruloplasmin less than 9.7, and 24-hour urinary copper 1053.16 microgram per day. Serum IgG was elevated 3340. And we did the detailed autoimmune liver disease profile, and it came out as many things were positive: anti-LC1, anti-LKM1, SLA, anti-SP100, anti-PML, anti-GP210. So AMA, Rho 52, and M23E were negative. So this was very significant, and after she presented to us, we continued the same management with penicillamine 250 mg, TDS with azathioprine and tapering dose of steroids. And she has improved symptomatically. We can see the improving LFT trend. Total bilirubin from 1.9. This is on 23rd July, August, and September. She's been following with us regularly. So bilirubin has decreased, and INR also has improved with even enzymes have improved. So this is a very good sign. So patient is improving with decreasing bilirubin and improving INR. So the plan is to taper steroids and then stop and continue azathioprine along with the penicillin because of the dual pathology of Wilson and autoimmune. I just wanted to tell that the coexistence of Wilson with autoimmune hepatitis is rare, and only a few cases have been reported so far in the literature. So I've just taken a snapshot of one article. This was also in Tamil Nadu. They studied about 10 patients who had features of Wilson's and autoimmune, and they studied their clinical presentation and lab investigations. And they had come to a conclusion. The result was patient had varied clinical presentation like abdominal pain, distension, pedal edema, upper GI bleed, and even they had a laboratory marker showed strong positivity in ANA, anti-LKM, ASMA. So all these were positive, and they also treated with penicillamine with steroids simultaneously, and patients have improved with that treatment. Thank you. I would like to conclude that this is a famous British neurologist, Dr. Samuel Wilson, and he had done a study on this Wilson's disease, lenticular degeneration, and he had coined the term extrapyramidal disease also. So, because of him, we have come to know of this disease. Yes, thank you.
Okay, thank you, Sneha. So, the first thing is once you at the end of the history. So, even though the patient, we have seen the patient after 3 or 4 months, but basically patient presented with a symptom duration of about 4 weeks to 1 month. Okay, so the question which has been raised in the one of the chat box is this acute hepatitis symptom? Patient symptoms are for 3 months, more than 3 months. So what do you say about that? Is it acute hepatitis or is it chronic hepatitis?
Yes, ma'am. To say it as acute hepatitis, it has to be less than 3 weeks, and chronic hepatitis will be around 6 months or more. So this patient, when she presented in Hyderabad, she was falling into that acute hepatitis criteria. So I have kept that in this temporary that diagnosis as acute hepatitis. But now that she's diagnosed as Wilson and autoimmune, the term chronic liver disease can be applied.
So if somebody has come to you with 4 months duration of hepatitis, like jaundice, the primary presenting symptom here is only jaundice and probably some pedal edema. That is the only symptom. Okay.
Yes,
so 3 to 4 months history of jaundice. So then what are all the differential diagnoses?
Okay, ma'am. So, because we will be first evaluating if any genetic here, because this patient had some consanguinity history in the family. So we are thinking in more in terms of heritable conditions. Otherwise, we can say the diagnosis can be metabolic or any autoimmune conditions because of this age group, autoimmune, and any drug-induced history. But in this case, she took the native medication only after she developed jaundice. She didn't she didn't have any history of drug intake before that. So only after that. So we can only tell that it's an overlay on top of any existing liver condition, like in metabolic or autoimmune. So to evaluate that in lab investigation wise and doing autoimmune markers, we can come to a conclusion what is the etiology and proceed accordingly.
So what are the some medications which can trigger autoimmune hepatitis? So you have described all the investigations. So patient seems to have classical Wilson's. So there is no doubt about the Wilson's in this patient. So ceruloplasmin is very low. Patient had KF ring, urine 24-hour urinary copper is very high. So the diagnosis of Wilson's is not in doubt in this patient. So the only other additional features were the does she have any autoimmune hepatitis? So she had some autoimmune markers which are positive, and the biopsy showing features of. So what are some drugs which can precipitate autoimmune hepatitis like feature? And what are some native drugs which has been published recently which can precipitate this kind of hepatitis?
Okay, ma'am. Native drugs, not sure. Usually, all this heavy metals, any native drugs with heavy metals, they can precipitate. They are very injurious to liver as well as the kidney. So, but specifically, I'm not sure
Recently,
of
they have
latest.
published this Gilloy-induced autoimmune like hepatitis. So some we do not know. Probably she had some pre-existing Wilson, and then what kind of native medications she took, we do not know, which would have added an autoimmune component to that. Okay, so if you had seen the patient first, so when the patient came to us for all the other attendees, when the patient came to us, patient was already on steroids and then on azathioprine, and the D-penicillin also was started. And so that's after when they came to us. And then the patient had the liver functions has started improving, so the steroids have been tapered. So now how, if it is just pure Wilson's disease, now how are you going to monitor the treatment for this patient?
Okay. If it is pure Wilson, then we'll be giving D-penicillamine around 1 to 1.5 gram per day in divided doses. That is 250 mg in divided doses, and we'll be monitoring it with any 24-hour urinary copper elimination excretion around once a month, or when she's coming to us for a review, we can check her 24-hour urinary copper and this ceruloplasmin values. So we can monitor like that. And even if she had presented to us with autoimmune hepatitis, maybe we would have given a trial of steroids and then seen if the changes were reversible or symptoms were improving, and then later on slowly started with azathioprine. That is also there.
So if it is autoimmune hepatitis, do you think it's type 1 or type 2?
It's more in favor of type 2 because she's a child and who has anti-LKM positivity. So it's more in favor of type 2 autoimmune hepatitis.
So we have some questions from the chat box. So, so somebody is asking, what was the stiffness due to? So she had some leg stiffness. So what do you think that was due to? Does she have those symptoms now? What do you think?
Yes, ma'am. Actually, she was having a stiffness while walking, but she's able to walk. But she noticed that symptom and she told it. So it is probably early beginning stage of neurological symptom. So it has not progressed progressed rapidly. And even while writing, she gave history of change in handwriting, but she was more worried about the jaundice, so she was not talking much about this. I have probed and asked her. She said it was there. I've noticed it, but now it's not bothering me. So this was
Probably
what
some early neurological
early
involvement is there.
neurological. Yes,
Involvement is there. Okay. So the other questions in the chat box. So is there any role for zinc? They have asked. So was zinc given? What is the role for zinc in her?
in Wilson.
Wilson's for
Zinc
her.
is also zinc is also an alternative agent which is used in treating Wilson. Like penicillamine, it excretes copper in urinary excretion and it promotes its mobilization, whereas zinc acts through GIT. It inhibits absorption at the GIT level, intestine level. I don't think both together is necessary in this case. Penicillamine is always the first drug of choice, and zinc always has more side effects like gastritis and IDA. I think penicillamine is.
The side effects are more with definitely with D-penicillamine. See, she is already has clinically yes decompensation. So, do you think she has decompensated liver disease?
To say decompensation, like patient should have at least a splenomegaly, any ascites with any variceal bleed or hepatic encephalopathy. She didn't proceed to that stage, so I didn't use the term decompensated. So I just said as.
But she definitely had an advanced liver disease, and then her INR was high. So zinc, we need to definitely give a chelating agent and let the copper be excreted as much as possible. So zinc may be considered at a later stage, but not now. If the patient has come in an asymptomatic stage means so one sibling is positive and the other sibling gets evaluated and we diagnose Wilson's. That time probably zinc can be given. And then somebody has asked a question, well, how long you will give D-penicillin? So how long are you going to give?
Ideally, we will be giving this lifetime itself, and along with that, we will advise her to even not take any diet rich in copper, especially any chocolates, nuts, mushroom, or anything which can add extra copper to the diet, along with the medication. And we will be giving other general advice as to not to eat in copper vessels or even in drinking water. Copper level should be monitored. So all those are additional advice we will be giving along with giving penicillamine.
Yeah, so D-penicillamine they have to take for a long time, probably lifelong, because that is and the patient has probably now, if we had not started the treatment, should have probably gone into a decompensated state. She has now come back to the compensated state. INR has improved. Okay, how about your Azeron? So patient steroids have been stopped. How long are you going to give Azeron now? Are you going to continue Azeron? How are you going to take that decision?
Okay, ma'am.
Not sure.
Yeah,
Okay.
I'm not sure about that exactly. I think.
So why do you say this patient has got autoimmune hepatitis? What are the typical features of autoimmune hepatitis in the liver biopsy?
We have seen this lymphoplasmacytic infiltrate. So, plasma cells being there itself is significant along with lymphocytes. And this rosette formation is also very typical of autoimmune etiology. So, these and interface hepatitis, the site is important, interface hepatitis. So, all this is very typical of autoimmune. So, the liver biopsy was largely in favor of autoimmune hepatitis.
So it is not a common presentation. So usually whenever we any disease, we think of usually one etiology. So we have to be very, very careful before we give a double etiology for a clinical presentation. But here it can many features are there. Okay, so somebody has asked, patient had splenomegaly with prominent esophageal veins with coarse architecture. Can it be cirrhosis related? So does this patient have cirrhosis?
Yes, ma'am, it has progressed. Like macronodular cirrhosis is seen in Wilson. So,
So does our patient have cirrhosis?
yes, ma'am, patient has cirrhosis.
Why?
She's already in that cirrhotic stage.
So the imaging shows some coarse echo texture. Okay, some prominent esophageal veins were there. But what did the biopsy show?
Biopsy mainly showed, yeah.
F3. So, but then that is what do you say? Sampling. So, because of sampling from where you pass the needle, sometimes it can appear as F3. So we can't really say it is F3. It has to be F3, F4 fibrosis. So most probably the patient has got cirrhosis from underlying Wilson's, and then this present worsening can be from autoimmune related disease. And at least for a year or two, we have to continue Azaron, and then later we can take a decision whether we can stop it or not. Okay, so I think we have. Thank you, Sneha. It is a very interesting case. So we will give it to our next presentation.
Okay, thanks once again, Sneha, for excellent presentation. Now we'll switch over to Dr. S. Palaniappan, who is the senior most consultant gastroenterologist in our center, and he's also the interventional GA endoscopist, and he's going to present an interesting case of paraduodenal lesion. It's over to Dr. Pioneer.
Dr. Palaniappan? Yes, very good.
Respected senior faculty members, my
Yes,
colleagues.
slideshow.
So I'm audible, sir.
Yes, you are. You have to click on the slideshow.
Slideshow.
Full screen.
Full screen. Full screen. Escape. Escape.
Slideshow.
Slide. No, slide.
No, slideshow.
Show. Play.
I'm audible, sir. Hello.
Yes,
Now you are.
Yeah. Respected senior faculty members, colleagues, friends, and my dear students. Good evening, all of you. The topic of discussion is about a case with paraduodenal lesion. He was a 38-year-old male, an IT person working in the United States, who developed acute watery diarrhea in September 2019. 2 to 3 times a day, lasted for 3 weeks. Diarrhea was not associated with pus or blood or any other clinical issues like joint pain, eye pain, jaundice, weight loss, any similar illness ever
Pioneer,
before.
you have to change. Sorry to interrupt. You have to change the slide. Make it full screen.
So it's already full screen, sir, here.
Okay. The second slide has not come. Only the introductory slide is there.
My second slide I am watching, sir.
Okay, do you want to just share the screen again? I am taking access from you for a moment. Now click on the share option and share the screen again.
So I'll click the share option, sir.
Right. Now it's full screen. You may continue.
Is it okay, sir?
It's okay now.
Yeah. My patient is a 38-year-old male, Indian national working at United States, who developed acute watery diarrhea in September 2019. It lasted for 3 weeks, 2 to 3 episodes a day, with no pus, blood in stool, no joint pain, eye pain, rash, jaundice, weight loss, any new medications, or otherwise he was healthy till then. He doesn't have any other medical issue. Family history is okay. The only thing what he says is he has taken quinoa seed, which people in USA take instead of rice 2 weeks earlier. After this episode, he traveled down to India, native of Coimbatore, where he was evaluated. This case was evaluated in 3 different centers, 1 at his native place, 2 at our center, and then for personal reason he has to fly back to US where further follow-up was done. I will take you this clinical journey as it happened. So at Coimbatore, October 2019, he was evaluated. Labs apogeoscopy was normal. USG, pancreatic protocol CT and FDG PET was done by the faculty there. They noted a 2.7 centimeter paraduodenal lesion, a right upper paratracheal node, for which he underwent endobronchial ultrasound evaluation under general anesthesia. Cytology showed no growth. Culture was negative. They presumed it to be a benign cyst. And at this point, to evaluate the paraduodenal lesion, he was referred to our center for EUS. EUS was done. And this is the CT coronal section, which this is the lesion which we are speaking about. A well-defined round lesion, paraduodenal. This is the duodenum and this is the lesion. This is a coronal section. And the next one is the axial section, the same lesion what is seen here. Radial EUS was done. I would like your attention towards 2 o'clock, where there is a well-defined, round, homogeneous, hypoechoic lesion. Most probably should be a node. And if it's a node, it has lost its architecture, and anything more than 1 centimeter, we know it is going to be malignant. This node was targeted by a 19-gauge biopsy needle, FNA-B, and this is the clipping of it. Histology was returned as a well-differentiated neuroendocrine tumor with a mitotic activity of less than 2 per 10 hypo field. Because of lymphoid cell aggregate, Ka index assessment was not clear. IHC chromogranin synaptophysin was positive. And now we know that it is a neuroendocrine tumor with nodal metastasis. Where is the primary? That is the point of contention for us now. And we plan for further workup. But due to pressing reasons, he had to fly back to United States, where further workup done, which I will project it to you later, which I got it through email and WhatsApp communication as and when it happened, verbatim. A short description about neuroendocrine tumors of small bowel. They are less than 4% of GI neoplasms, but 50% of them are neuroendocrine, as shown in this graph. What I want to stress is the incidence is on the slow rise, which exceeds even adenocarcinomas. How do they present? They are indolent tumors, slow growing, heterogeneous and diverse with varying clinical history, natural behavior, therapy response, and prognosis. Some of them, or even many of them, could be functional. In that case, it could be a secretory syndrome. Because of low awareness and indolent nature, there is a diagnostic delay of 4 months to 9 years in certain cases, and hence they do present with advanced state. What are the clinical symptoms? It's very vague. Abdominal pain, anemia, GI bleed, weight loss, and some can present as bowel obstruction, which could be recurrent. This is because of the desmoplastic reaction of the tumor infiltrating the mesentery, which can cause either a recurrent bowel obstruction or they can infiltrate the major vessels and can cause mesenteric ischemia. They also can present with retroperitoneal fibrosis, which in turn can present as hydroureal nephrosis. These are epithelial tumors with neuroendocrine differentiation and have a capacity to produce amines and hormones. Their grading depends upon the mitotic activity, and the proliferative activity depends on the expression of Ka67 protein, which is the nuclear protein. It tells about the proliferative activity. Site specificity, last 60 centimeters of ileum predominant, and the next common is that there's a very slow rise in the rectal NETs, and next comes appendix. NETs have been found to be more common in this predisposing factors. What I would like to stress is patients where there is a family history of cancer or patients who have a relative of NET, we have to have a high suspicion. And like to stress that it could be a part and parcel of a syndromes like MEN1, VHL, or neurofibromatosis or tuberous sclerosis. Classification could be varied, gut specific, foregut, which involves lung up to stomach and duodenum, or midgut, jejunum and ileum, or distal. Histology based, it could be well or poorly differentiated. Secretory based, it could be functional or non-functional. Differentiation based, it could be any neuroendocrine tumor or neuroendocrine carcinoma. The WHO classification tells us that how we have to grade them, grade 1, 2, and 3, based on Ka index and mitotic index. And if they are more than 20 in each, and if poorly differentiated, they are with high Ka index and Mi index. So, what is the management protocol? There are different international societies which give us guidelines, evidence-based, like NCCN, European Society of Medical Oncology, North American or United Kingdom and Ireland NET Society. We have to depend on any one and follow it up. The staging based on AGC type. The fundamental approaches on these three headings: biochemical markers, imaging, and histopathology. Biochemical marker, the highly dependent one is chromogranin A, 70 to 80% sensitive, commonly used. The baseline value predicts outcome. Unfortunately, it cannot be used for screening, and the specificity is low, meaning it can be positive in patients who are on long-term PPI or any failure, renal, liver, or congestive cardiac failure, or even in patients with simple systemic hypertension and gastritis. So we have to rely cautiously on this value. Molecular marker, neuroendocrine test is a liquid biopsy, which is a kind of neuroendocrine tumor expressing in the blood. It's a unique signature. It precisely defines the biological activity of the tumor in real time. And it is superior to chromogranin. And the three critical requirements of an optical marker are met: diagnostic accuracy, assessment. The only thing is it needs more clinical validation before it comes into clinical org. So then, what's the role of ultrasonogram? Many patients can present with metastasis. When ultrasound can pick up, we can conveniently do a biopsy, and by IHC marker, we can identify the primary site from where it has spread. Otherwise, its main role is in intra-op screening and maybe sensitivity very high with contrast ultrasound. So essentially, it is not much useful unless there is a very large liver mets. So the fulcrum of diagnosis is based on imaging. Anatomic imaging, we are all very aware, multiphasic contrast enhanced CT, as well as high Tesla MRI. CT is easily available, but the anatomic definition is very low, sensitivity is poor. MRI also, where anatomic definition is low, but it can score over in identifying liver mets. So the workhorse is depending on the functional imaging, that is, these tumors are somatostatin receptor expressing tumors. SSR1, 2, 3, 4, and 5. Based on them, avid sensitivity to these receptors, gallium DOTA-PET is the fulcrum of diagnosis. DOTA-NAC, DOTA-TEC, and DOTA-TATE. DOTA-NAC is much preferable for diagnosis because it is sensitive for all the 5 expressors, whereas DOTA-TATE is used for therapy. And then we have the glycolytic pathway-based metabolic assessment, FDG-PET. Where they are positive, when they are used, I'll come to it. What's the role of endoscopic ultrasound? May be used in gastric or duodenal net to assess the depth of invasion. That is whether they are limited to muscularis propria. They're limited to submucosa or extended to muscularis propria. And in pancreatic NET, diagnosing the tumors. So this is the literature support of much superior of PET-CT evaluation in neuroendocrine tumors. They are highly sensitive, highly specific, and accurate when compared to CT. So having diagnosed, what's the management? We know that given tumor is either low grade or high grade, grade 1, grade 2. What's the Ka index? Anatomic imaging. And then the most important thing is the functional imaging. Somatostatin receptor positive or somatostatin receptor negative with FDG positive. This itself tells us that whether they are indolent or aggressive nature. And the treatment of option is surgical resection is the order of the primary as well as the nodal metastasis, even if it is metastatic to liver. If it is limited, the liver metastasis has to be resected. If an extensive liver mets, even then debulking primary is recommended for symptom-free survival and progression-free survival. So surgery is the first line. And then comes the systemic therapy. The first line is long-acting somatostatin analogs, octreotide, lanreotide, pasireotide. If they are not responsive, we can escalate the dose. If still progressive, then we have the new armamentarium, what is called peptide-based radiotherapy, yttrium. I'll come to it in the next slide. If they're aggressive tumors, high grade, then chemotherapy. Liver mets, if unresectable, local therapy. Do we have a role for transplant? In a very subselect cases, Milan NET criteria says that patients with less than 60 years old, less than 50% involvement of liver, low-grade tumors, tumors drained by portal vein, and the tumor progression is static for 6 months, we may embark. So it's a highly subselect cases. The guidelines vary on this. Now, this is one of the most important slides I want to catch your attention towards. Histopathology directs the subsequent therapy. We presume that all sites of metastasis have a similar phenotype. It is not so. It is increasingly recognized that analysis of a single tumor biopsy will present a major challenge for a personalized optimal care. What does it mean? While imaging in a functional way, it is ideal to do a dual DOTA PET and FDG PET. That is to identify the tumor heterogeneity. That's in a given tumor, metastasis at different sites can have heterogeneity. For example, the tumor at different sites can be somatostatin receptor positive. That is, if you look at P1, FDG negative. So they are clearly amenable to second line PRRT therapy. If you look at the bottom, where, if you look at the bottom, here, somatostatin receptor DOTA is negative, FDG is positive, which clearly says that this case are not amenable to PRRT. But in between them and bulk of them are sensitive to both. So what we have to see is whether it is FDG less await when compared to somatostatin receptor screening, FDG is equivalent to somatostatin receptor screening, or FDG is greater than somatostatin receptor screening. This is the first what you have to assess. And then we have to assess how many lesions are there. So based on that, these are the group which respond if they are progressive to PRRT therapy, that is peptide-based radiotherapy. These are the group which will not respond, and these are the group which we may try. That is, even when they are FDG positive, which we will understand only when we do a dual imaging to understand the heterogeneity. So this is an overall view of all the neuroendocrine tumors of GI. I'll just briefly touch upon appendiceal. Less than 2 centimeters, appendectomy is enough. More than 2, right hemi. Gastric, type 1, type 2, type 3, depending upon the size, endoscopic surveillance or resection. And these are the tumors which have more or less the same approach. But bottom line is, how we approach is based on histopathology, imaging, functionality, and extent of the disease. And we have to assess the rate of the tumor growth, the performance status of the patient, and their preference. And we have to rule out whether they fit in within any familial syndromes. And finally comes what is the availability there in your center. A few words on carcinoma crisis is more common with jejunal-ileal NETs. Patients may suddenly present after even a simple biopsy or any intervention or surgery. Serious sudden hemodynamic instability, flushing, diarrhea, severe bronchospasm. If we know that the patient is a neuroendocrine tumor, we have to suspect. If not, it is difficult to address this issue. The most important point is routine, regular resuscitation with IV fluids and vasopressors, these will not respond. Then what we have to embark on? IV octreotide is the only thing which is going to rescue the patient. And another point is it's mega dose, 500 to 1000 micrograms, stat followed by 200 micrograms every hour. So having diagnosed is more common within the first 8 years. What to follow? Clinical, imaging, and biochemical assessment. How frequent? Twice a year in the first 1 year, and then every year for next 10 years. What's the prognosis? Median survival is 9.3. Appendix has a very good prognosis compared to rectum and then the pancreas. This is the slide which shows that appendix has a very good prognosis for even grade 1 and grade 2. and here comes the rectum, and then poor prognosis for colon, and then the liver, least one. So having spoken briefly about small bowel neuroendocrine tumors, what happened to this case? I could get the detail from him from United States, the center where he was evaluated. There, the treating faculty understood, thought of that this being a rare, complex scenario. The evaluation what we have given didn't reveal the primary, so he was completely re-evaluated there. Upper GI was done, DOTA PET, FDG PET, and an endoscopic ultrasound. Unfortunately, no additional information could be gained further beyond the periduodenal node. Hence, with the intent of cure and resect the node, laparotomy was undertaken. The periduodenal node was excised. At this point of time, the primary surgeon decided to call upon an international expert in this unit who has a wide experience and a very robust amount of literature and highly experienced in the surgical management of neuroendocrine tumor. Dr. Norton was called in. These are all I got it from the discharge summary what he texted to me by email. They both joined in the surgery and they did a thorough manual palpation of duodenum and small bowel. Couldn't identify the primary. Then an intra upper GI was repeated. Up to D4, it was normal. And then the surgeon decided that they will, given the proximity of the node and the possibility of being a duodenal primary, they did a duodenotomy. Initially, it was normal. Then again on careful inspection, they could identify a very, very tiny nodule, post-pyloric region, excised, frozen section was returned as well-differentiated neuroendocrine tumor. So this is a case of duodenal NET involving the first part and anticipating a need for long-acting octreotide, which could precipitate gallstones. A prophylactic cholecystectomy also was done. All this happened in 2020 early, and this patient is in regular clinical biochemical imaging follow-up. Biochemically, his chromogranin and gastrin levels, which was initially done there and then subsequently also, is on a very good regressing trend and is normal now. So this case was presented for the following reasons. To understand that it is an evolving field and increasing in incidence. Initial presentation itself, neuroendocrine tumors can present with metastasis. Primary could be extremely elusive because they are all sub-centimeter. Prior to curative surgery, dual imaging is ideal. That is DOTA PET and FDG PET. Neuroendocrine tumors of small bowel warrant laparotomy and not laparoscopy because meticulous palpation by your hand of the entire small bowel is mandatory. Why? Because primaries are noted to be sub-millimeter and multifocal in 50% of cases, which even a DOTA PET can be falsely negative. And most important thing is pre and peri-op IV octreotide is to be instituted to avoid a possible risk of carcinoid crisis. And the dose of octreotide, what is recommended is mega dose. And this is one clinical scenario where a prophylactic cholecystectomy is to be done. So I like to conclude that it is imperative for all of us to maintain a familiarity of this ever-expanding armamentarium available for optimal care of these patients in a multidisciplinary team approach. I thank you all for your patient hearing. Would like to take up questions and would like to learn from other faculty also from their experience of neuroendocrine tumors. And if possible, we can have a registry of neuroendocrine tumors to have our own Indian data on this rare tumor, though with increasing incidence. Once again, I thank you all.
I think there are no questions on the board. I would like to ask Paniappan
Yes, sir.
You're telling something about the millets the patient has taken.
Yeah.
How this is relevant in this case and why it has been mentioned.
Sir, one verbatim I have given the history. That is the first reason. Second is diarrhea. After he returned to India, diarrhea stopped. And he also gave an history that his family member, that is his wife, also had diarrhea. So in this case, my doubt was whether diarrhea is related to the seed, which incidentally helped him to, fortunate enough for him to identify this pathology itself. Otherwise, it would have gone unnoticed. Or whether there's an underlying secretory syndrome, I don't know. But I think it is not a secretory tumor because the diarrhea stopped on its own, possibly related to the seed what he has taken.
So you mean to say this diarrhea made him to get worked up? Otherwise, he would have
Possibly,
got
sir.
diagnosed.
That's what I think possible because the diarrhea stopped the moment he landed in India. Had it been a secretory diarrhea, without intervention, I believe it is difficult for us to understand how it would have stopped.
How this submucosal nodule, which has been found only by palpation with the duodenotomy, is a chance that they can be missed even in the US and all?
Yes, sir. Endoscopic ultrasound sensitivity may be very high had if we use a probe EUS. That is, we are using a standard EUS where the frequency what you use is only up to 12 megahertz. Whereas a miniature probe EUS, which has a frequency up to 20 megahertz, probably would have picked it up, possibly, because it is a nearby resolution is very high. And data pet false negative scenario is in such cases where it is submillimeter nodules. That is why the recommendation is literally manual palpation of the small bubble, something like we get screened in the airport. We have to screen, palpate like milking, which they did it. Yeah, the answer is the standard echoscope.
So the PET scan done there, both the SSRI and FDG did pick up the primary.
The primary was elusive, sir. Both in Coimbatore as well as in United States, because in USA they repeated everything. In fact, he told me that he's getting evaluated again. I was a bit waiting with bated breath that something new will crop up, which we have overlooked.
What is the prognosis in this case?
The 5 year survival is
Probably only locally spread and not distantly spread.
yeah. 5 years survival is close to 80 to 90%. Sir.
There were no questions from anybody.
There are a few questions in the chat box.
Is it there, sir?
I'm not seeing any questions in here, sir.
I'm also unable to see any questions. Pandipan, in your experience, how many cases you have seen of
Sir,
this kind of
small 5 mm, less than 10 mm lesions of stomach, we have started seeing them, and of late in the past 3 to 4 years. I think at least one per month, 1 or 2 per month we are seeing it. Sir.
bulb? You have seen no lot of nodules in the bulb came as a benign carcinoma. No,
Possible from stomach fundus, submillimeter.
during a bulb also. During a
Dual
bulb,
bulb also, sir. We are seeing.
sometimes it may mimic a benign nodular hyperplasia.
Yeah.
No.
Type 1 gastric NETs we are seeing frequently. Duodenal NETs also, tiny submillimeter nodules we are seeing it. They are all non-functional, incidentally picked up. which biopsy proves it.
Okay. Dr. Hema, are you able to see any questions on the board? There are no questions, no?
No, sir. No, I can't see, sir. There are no questions
Even
in the
in
chat
my
box.
screen also, I'm not able to see any questions on chat box.
So I think we have answered some 4 or 5, which was for the liver case,
Yeah, yeah.
which has been answered.
Can I